So it's an exceptional honor to be invited today to give one of the two state-of-the-art lectures on post-traumatic stress disorder. This is a field I've been concentrating my research focus in the past 10 years, and I will try to summarize what we know and what we may want to know in addition, so state-of-the-art and beyond. And I will start right away in order not to lose any time with the definition of PTSD. PTSD is defined as a trauma and stressor disorder following a psychologically distressing event outside the range of usual human experience. PTSD was classified in DSM-4 as an anxiety disorder. Now in DSM-5, there is a whole new chapter, trauma and stressor-related disorders. PTSD symptoms are, of course, not new. They exist since the beginning of humanity. There are many works referencing PTSD, even in the Epic of Gilgamesh, in Homer's Iliad, and in the Persian Wars. But perhaps the first attempt to define a syndrome was during the French Revolution by Philippe Pinel, cardiorespiratory neurosis. During the Industrial Revolution and railway accidents, it was a very sexy term back then, the railway spine. And the Franco-Prussian Wars gave Oppenheim, Königsmann, and Kroc a step to coin the term traumatic neurosis, traumatic hysteria, and war neurasthenia. And of course, during Civil War, this is a very famous syndrome, the soldier's heart, or Da Costa syndrome by Jacob da Costa, a surgeon during Civil War. In the more recent years, World War I, we were talking about shell shock, and Emil Kraepelin was talking about war shakers. World War II, we were talking about combat neurosis and combat fatigue. And a little bit after World War II, DSM-1 classified for the first time the so-called gross stress reaction. This was not included in DSM-2, but after the Vietnam Wars, DSM-3 classified for the first time PTSD as a diagnostic entity. Let's check a little bit some facts about trauma epidemiology. You see that in several countries, the amount of general population having faced a traumatic event is over 70%. But as a general rule, you can remember that almost 50% of the general population has faced trauma in their lives. And of those, 20% of women and 8% of men will develop PTSD in their lives. The epidemiology of PTSD, we have to separate civilians from combat-exposed military personnel. In civilians, in general population, the 12-month prevalence is 1 to 4%. It's not much, but if you check the lifetime prevalence in women, it's 13 to 20, and in men, it's about 6 to 8%. This is very important. This means that almost every fifth woman will have to deal with PTSD during her life. You see here significant prevalence differences across nations. You see here, for example, Northern Ireland, very high percentage, other countries less. But this has to do with several factors. Let's go to the combat exposed military. Here we have even higher numbers, 20 to 30% lifetime prevalence of PTSD. This is huge. This is 1 out of 3. When it comes to the diagnostic criteria, this small figure summarizes the diagnostic criteria of DSM-4. We need a traumatic event. We need re-experience symptoms, avoidance symptoms, arousal symptoms, the duration of at least a month, and the functionality item. However, DSM-5 has added a new criterion, criterion D. This includes cognitive distortions and mood symptoms. So we need actually 8 criteria to be fulfilled in order to diagnose PTSD, and a duration of at least a month. Everything up to a month, we're talking about acute stress disorder, and after 3 months of persisting symptomatology of chronic PTSD. Also, something new in DSM-5 is the classification of two new subtypes, the dissociative subtype and the delayed subtype, with a delay of at least 6 months. In contrast, ICD-11 has probably will not take into consideration cognitive distortions and mood symptoms as DSM-5, and will remain with re-experiencing symptoms, with arousal symptoms, and avoidance symptoms, as in DSM-4. So in order to diagnose PTSD, we need a traumatic event, we need direct or indirect trauma exposure. We need a person to fulfill symptom criteria, at least one intrusion, one avoidance criterion, 2 or more cognition and mood symptoms, and 2 or more arousal symptoms. The individual has to suffer for at least a month, and we need an impairment in functionality in order to diagnose PTSD. The course of PTSD is not an easy issue. We have several different courses. We have the delayed onset, we have the persisting subtype, we have the partial PTSD, rest symptomatic, and we have several other course types. This is something we will be talking a little bit later more to explain that. I would like to take another minute to also show you what is complex PTSD. So we have PTSD as defined until now, and we have complex PTSD, which has additionally affect dysregulation, negative self-concept, and interpersonal disturbances as additional criteria. This is something, it's only classified in ICD-11 and not in DSM. And this is a symptom cluster that we meet in individuals having a repeated exposure to childhood and interpersonal trauma. These cluster of symptoms reminds us also a little bit of borderline personality disorder, and you see here the distinct overlap between the two. So just please keep it in mind when you see a patient with borderline personality disorder, you should perhaps acknowledge complex PTSD if you have the criteria met. The psychiatric comorbidity is a huge topic in PTSD. It's perhaps the psychiatric disorder with the highest comorbidity rates. You see here, over 80% have at least one mental health comorbidity, and over 60% have 3 or more. This is really exceptionally high numbers. Something very important is the overlap between traumatic brain injury, TBI, and PTSD. We know that soldiers mostly, or civilians having TBI and in combination with loss of consciousness tend to have over 80% possibility of developing PTSD. This is a huge number. And of course, last but not least, over 2 times higher risk for developing dementia in PTSD patients. Here are some numbers. You can see comorbidity over 50% with major depressive disorder, alcohol abuse, drug abuse, and also the overlap here with traumatic brain injury. Many symptoms are alike, but there is also one issue that has to be pointed out. This is suicidality. We have suicidal attempts in over 30% of PTSD people, 2 times the risk of completed suicide. This is a huge issue in veterans, VA care, considering also the fact that military personnel has also access to firing weapons. But not just the psychiatric comorbidity, also physical comorbidity is extremely high. You see here highly significant differences between individuals with PTSD and not PTSD with respect to pretty much every somatic disorder. You see here extremely high rates in rheumatology, in gastroenterology, neurology, endocrinology, and cardiology. 2 to 3 times higher risk to develop a physical disorder comorbidity. Perhaps I should take another minute to point out the importance of sleep disturbances. This is, of course, one of the symptoms assessed by DSM, but we have to say we neglect a little bit the importance of sleep disturbances in the development and persistence of PTSD. We have up to 90% insomnia and up to 70% nightmares. And this combination of hyperarousal, sleep avoidance, but also biological measures as fragmented REM sleep and higher REM latency, parasomnias, and other nocturnal behaviors has led to the definition of the so-called trauma-associated sleep disorder, which is a very distinct pattern in these individuals. And of course, sleep disturbance is not just a symptom of PTSD, but it's also a very crucial risk factor. We know that people with pre-existing sleep disturbances before trauma exposure can have up to 3 times elevated risk of developing PTSD. This is a very high number. Additional risk factors. We know that there are specific genotypes linked with the development of PTSD. On the left hand, you can see the publicated research, but I just selected one example of perhaps the most prominent genotype. We're talking about serotonin reuptake inhibitor genotype. So the transporter genotype, and we have the SS, the SL, and the LL alleles. We know from depression and childhood trauma that the SS allele has had in the past higher risk of developing mental disorders. What you can see here is a significant gene environment interaction. But after the first exposure to trauma, so you see here in the first and second trauma, there is not much difference, but as the trauma accumulates in 3 or 4, we have a significantly higher risk to develop PTSD in people with the SS genotypes. Another risk factor might be the pre-existing inflammation. This is a study conducted in San Diego during my postdoc, published in JAMA Psychiatry back then, where we have shown that pre-deployment CRP, so inflammation marker in plasma, was associated with the probability of developing PTSD after combat exposure. And if we try to take together all risk factors, we know there's a pronounced genetic susceptibility. Not only the polymorphisms, but also gender plays a significant role. We know that early environment plays a very significant role. Early life stress and trauma, fetal programming, all of these play have an enormous contribution to what we called allostatic or cacostatic load. This includes the altered neuroendocrine responsiveness and also altered brain development, sleep dysregulation, and an additional factor, lifestyle. This might be influencing as well. Of course, the type of trauma is very significant for the development of PTSD. However, not really just the type, but pretty much the subjective quality and the objective quality of trauma. So we know, for example, that man-made traumas like rape can lead to a significantly higher risk of developing PTSD. Also, the role of the individual victims have higher risks than witnesses. The repetition, if it's a single trauma or repetitive trauma, the accumulation, if we're dealing with several types of trauma, or is it just a single one? If it's acute or chronic, the developmental stage, of course, the earlier in development, the higher the risk, the subjective intensity, circadian timing, when exactly is the trauma happening, in the day or in the night, and some other features as novelty and so on. And you see here the different effect that different types have on the development of PTSD. You see here being a witness although it is very common, you don't have high numbers of PTSD individuals. However, when we're talking about childhood trauma and of course rape, um, sexual assault is perhaps the one type of trauma leading to the highest risk number of PTSD. You see here rape reaches almost 50% in the development of PTSD. We have talked about the accumulation of trauma, and this is dose response curve as it's predefined. The more trauma someone faces in his life, the more the probability to develop PTSD. However, this curve reaches a plateau at about 30%. This means that almost 70% of the people, even when facing additional trauma, will not develop PTSD, and this is probably the percentage of resilient population. So 30% is pretty much the top we can reach. So I will be talking a little bit also on about the neurobiology of PTSD, and I would like to start with a very biological definition of trauma made by Sigmund Freud. Freud was a biological psychiatrist in contrast to what most people think. He defined trauma as a stressful experience leading to such an extraordinary stress response that physiological adaptive processing fails, leading to long-term dysregulation of biological functioning. And exactly this happens in PTSD. We have a failing adaptive processing and a long-term dysregulation of biological systems. So what happens when we face a stressor, and not a trauma, but a stressor? This stressor gets accessed by the prefrontal cortex in combination with memory retrieval from the hippocampus. The prefrontal cortex decides if this is a dangerous stimuli or not and activates the amygdala. The amygdala activates also the limbic system, but also the main two pathways, downstreaming pathways. The first one is the hypothalamus, and the main part is the paraventricular nuclei, which also activates the HPA axis, and the brainstem nuclei with the locus coeruleus activating the autonomic nervous system. So these are the two branches of stress activation. So we have an autonomic and endocrine response, but also the emotional experience of the stressor. When we are dealing with mild stressors, so we have the PFC, the prefrontal cortex, exerting an influence on the amygdala and how the amygdala has to be responding. However, in extreme stress, the prefrontal cortex is disabled. It's off. So we're talking there about the amygdala hijack. So the amygdala takes over and has a very high response. It's blocking the functioning of the prefrontal cortex and dominates. This can happen if the stressor is too high, or if the stressor takes developmentally earlier pathways to reach the central nervous system, as olfactory stimuli, tactile, auditory, visual stimuli, reaching the thalamus and the amygdala directly without crossing the prefrontal cortex. These are experiences that tend to sensitize the stress system and leading to higher rates of PTSD. So what happens is we have the flight or fight response, and if the stressor is too high, we get over to the freeze compartment. So we have a fight or flight or freeze reaction. In this stage here, we have a dorsal vagal activation as a emergency brake, and then this freeze section here is actually the preparation for death, where we have pretty much always dissociation. And here we're talking about peritraumatic dissociation. When this happens, the chance of developing PTSD is enormously high. Normally, a stress response is in this middle area here. And of course, this is very important because the memory consolidation, which plays a role in PTSD, happens at night. So we have a nocturnal memory consolidation, and you can imagine at night we have very low levels of stress. So the hippocampus, responsible for memory consolidation, is used to work at low levels of stress. If we have a rise of stress like this, here you see the diurnal slope of cortisol. At night, we don't have pretty. We have we have a phase without any activation. If we have here a trauma at night, we have a system that's actually um, uh, not used to high levels of cortisol and autonomic uh, activation. And everything that happens in this inactive phase at night tends to have serious effects on PTSD risks because we have a very high HPA axis responsiveness at night. So traumas happening at night, bar fights, rapes, and also night operations in the military, these are highly traumatizing operations. Why this happens is also because the glucocorticoid receptor shows also a very diurnal change with respect to its sensitivity. And we know during night we have a very high sensitivity on glucocorticoids because we're not expecting high levels. This has to do with several circadian genes in the expression of the receptor. So what happens in PTSD? We have the first phase, the golden hours after trauma. This is the phase where many researchers try to find prevention strategies, how to alter the enhanced nocturnal memory consolidation happening in the first night after trauma because of the higher stress rates affecting the hippocampus. After this, we have an interplay between prefrontal cortex and amygdala in terms of increased fear conditioning, but also negative appraisal, increased threat detection, and attentional bias towards traumatic events or stressful events. This disables the fear extension learning that would normally happen and would normally allow people to go back to the normal state. And of course, this is something that turns on the avoidance possibility in our lives. We keep avoiding stuff. And this leads finally to disabled threat disengagement and response inhibition, which might be the cause for the very high number of re-traumatization between patients with PTSD. What are the areas involved? We talked about it. We have the prefrontal cortex, the amygdala, and the hippocampus. You see here for intrusions, for cognition and mood, together with the cingulate, and also for avoidance, arousal, and reactivity. These are pretty much always involved. So we're talking about the big three in PTSD, the hippocampus, the amygdala, and the medial prefrontal cortex. The amygdala, the model up to now was that the amygdala is hyper-responsive and the prefrontal cortex was hyper-responsive. So the connectivity was altered, and that the hippocampus had probably a reduced volume. However, some new evidence shows that this is pretty much a pre-existing risk factor rather than a result of PTSD. So we're dealing with these amygdala PFC interconnection. And the initial model was, as I told you, hyperactive PFC, hyperactive amygdala, and leading to hyperarousal with cortisol resistance and lower levels of cortisol. However, as DSM-5 has now defined, and as we know in the clinical practice, we also have another possibility. This is the other side of the coin. We have a hyperactive prefrontal cortex, decreased activity in the amygdala, and we have hypoarousal with depersonalization, derealization, emotional numbing, and so on. And this is the state that is now classified as the PTSD dissociative subtype. And I will try to show you that it's pretty much the same disease with very striking differences when it comes to pathophysiology. And this is something that we have proposed with together with Professor Cruces in a recent article, where we see a very high activation of the stress system at the beginning. After stress, we have a very hyperactive first phase with hypercortisolemia, and over the years, this tends to go down to the hypocortisolemic phase. But again, this might be the same thing, because hypercortisolemia, hypocortisolemia, in these two different states, mirroring states, is actually the same when it comes to the glucocorticoid signaling, because hypercortisolemia as well as hypocortisolemia leads to a glucocorticoid signaling associated disorder in all systems associated with the stress system, the metabolic system, excuse me, the immune system, and so on. And this is this model, again, from an immunological perspective. We have here PTSD as a disorder with an immunological component. And you see here in the first phase, in this hyperactive phase, we have pretty much the innate immunity and we have immune suppression, yes, in this first phase. And we have the second phase where we have the sickness syndrome with inflammation and a total different biological state, which is pretty much the same disease. So we have to start seeing PTSD as a continuum, and perhaps not just PTSD, but also depression and every stress-associated disorder. Because altered glucocorticoid signaling can lead to all of these dysregulations, and it's pretty much the same with circadian disruption. So a difference in the phase of glucocorticoid secretion and glucocorticoid sensitivity of the receptor.
I need 2 minutes.
And
2 more minutes.
Two more minutes. Okay. So I will be not summarizing by going directly to PTSD prevention and treatment. We talked a little bit about the primary prevention. So what happens before trauma? What we know is psychoeducation does not work. We are trying to see if attentional training, resiliency training, and sleep hygiene might assist towards lower rates of PTSD. Then we have the secondary prevention, where we are talking about the golden hours after trauma, where we know psychological debriefing, what we have been doing for the past 40 years, does not work. However, immediate trauma-focused CBT or hydrocortisone treatment seems to have an effect on reaching lower rates of PTSD. Other compounds are in research at the moment, opiates, beta blockers, and so on. But I will invest another 2 minutes on the treatment. And here we have psychotherapy and we have medication. The psychotherapy, I just have one slide. This is summarizing everything we know, that the first choice of treatment is trauma-focused cognitive behavioral treatment with prolonged exposure therapy, either in vivo or in sensu with narrative exposure and imagery represcripting. Number 2 is the eye movement desensitization and processing, EMDR. Has pretty good and decent evidence base, however, not so good as the first one. And here we have to say that it's probably the reprocessing doing the job and not the eye movement. And other techniques as interpersonal psychotherapy, mindfulness-based stress reduction, and so on, has a little bit of an evidence, but it's considered line 3 in the rank. In the pharmacotherapy, we have only 2 agents here that are approved, FDA approved for PTSD, sertraline and paroxetine. Of course, SSRIs and SNRIs have an effect. This is something that perhaps you wouldn't have in mind. The second generation Antipsychotics like risperidone, olanzapine, and quetiapine have very nice effects and efficacy on treating PTSD. Also prazosin, trazodone, topiramate. Please keep in mind less than 30% achieve remission. And this is a meta-analysis showing here topiramate, risperidone, olanzapine, quetiapine have the best evidence at the moment, followed by paroxetine, sertraline, and the SSRIs. When it comes to the guidelines, this is pretty much a mess. I can't define it other way because every national society has different guidelines. Some do approve pharmacological treatment, some do not. Here you see the NICE guidelines. They suggest CBT and EMDR, but not medication, while others tend to medication as first-line treatment. And the future brings us to psychedelics, glucocorticoids, light therapy, virtual reality. And when you see Dr. Rachel Yehuda, perhaps the most prominent PTSD researcher, talking about psychedelics, then you know the era of brain connectivity treatment as an assisting medication to psychotherapy has come, and perhaps we will be talking about prescriptions of MDMA and LSD later on in the pharmacist. Glucocorticoid treatment, same as in rheumatoid arthritis, a disorder that shares a little bit of a same background with PTSD. This might be also treatment of choice, and of course, more modern techniques like advanced or virtual reality exposure treatments, or even retiming through bright light. This is my final slide. It is not men who stops time, it is time that stops men. And I would like to thank you very much for your attention, and thank you, Professor Christodoulou, again for the kind invitation to participate in this lecture.